All right, why don't we get it started? We have a lot to cover this evening, so we should get on with the program. Good afternoon or good evening, everybody. Welcome to MDA Advocacy Institute, focusing on finishing 2024 strong, where we'll be reviewing our top legislative priorities for the remainder of the year. I am Paul Melmeyer. I'm the Executive Vice President of Public Policy and Advocacy at MDA, and I'm going to be your MC tonight, if you will. But we may have actually the largest panel of guests that we have ever had on one of our advocacy institutes, and that's because we have a lot to cover. You see, I'm just one of 6 individuals who are going to be speaking to you tonight. We're also joined by Haley Mason from the National Organization of Rare Disorders, Darcy Milburn from the ARC, Megan Herber from Faegre Drinker Consulting, and then Shannon Wood and Joel Kartner on the MDA team as well. So let me first tell you what we're going to be talking about. Let's go over to the agenda, because we're not all going to be talking about everything. That would just be a whole big mess. Instead, what we're going to be doing is we're going to be focusing on 3 specific legislative priorities that the Muscular Dystrophy Association is really hopeful that we can actually get across the finish line by the end of the year. These are bills that, generally speaking, are bipartisan. They have a lot of support across Capitol Hill. We know that they would make a big difference for many folks with neuromuscular conditions, and we're going to really be pushing them hard for the remainder of the year. We won't be doing it alone, and that's why we're going to have guests with us this evening, individuals who are experts in these 3 bills joining us to talk about them. So first, within the agenda, I'm going to say just a few words of housekeeping, but thereafter, I'm going to turn it to Joel Kartner, MDA's Director of Access Policy, and Megan Herber, and they're going to be talking about the Accelerating Kids Access to Care Act. From there, we're going to turn to Haley Mason at NORD, and Haley and myself, we're going to talk about the reauthorization of the Rare Pediatric Disease Priority Review Voucher Program. And after we go over that program, Shannon Wood, MDA's Director of Disability Policy, and Darcy Milburn with the ARC, they're going to be talking about the SSI Savings Penalty Elimination Act. Now, of course, these 3 bills aren't the absolute only things we're going to be working on. We'll finish out with a few legislative priorities. We're still going to be continuing, hoping that we can get past this year. So we'll discuss those at the very end. And then, of course, we'll also take your questions and we'll try to answer them. So let's move on to just a few items of housekeeping. We're on WebEx, and just to give you a little bit of idea how WebEx works from your point of view, our guests, there's a couple buttons you can see basically in the bottom of your screen there. On the far left, you see the closed captioning option. You can click that if you want to take advantage of closed captioning. And then also, we're hopeful that you will be asking fantastic questions of the MDA team as well as of our guests on all 3 of these issues. And to do so, what we recommend that you do is go to the very bottom right of your screen. You see those 3 little dots down there. And if you click on that, you see the Q&A. And if you click on Q&A, you can then submit a question to all the speakers. And for those of us talking about the specific issues, we'll try to cover your questions. But it's best to put them in the Q&A. There's also the chat box. It's a great place to be interacting with each other and so forth, but it's a little bit more unwieldy when it comes to questions for the speakers. So we do recommend the Q&A box if you can. And I'll also note that, generally speaking, for advocacy institutes, I know many of you have joined these in the past, we take questions at the end. We have presentations, we have discussion for the bulk of the program, and then we take your questions at the end. We will still take questions at the end, but we're going to do it a little bit different this time because we have 3 speakers joining us on 3 different issues. We're actually going to take your questions on those issues as we go along. So we'll talk about accelerating kids' access to care, and then we'll answer your questions on that. We'll talk about the voucher program, and then we'll answer your questions there. And then we'll talk about SSI, and then we'll answer your questions on that. But again, if you think about something a little bit later in the program you didn't have a chance to ask earlier, please still put it in the Q&A box, and hopefully we can still get to it at the end of our hour together. So with that, without any further ado, I want to get on with the program. I'm going to first hand it to Joel Kartner, MDA's Director of Access Policy, and he and Megan will talk about the Accelerating Kids Access to Care Act. So Joel, I hand it to you.
Hi, everybody. Great to see everybody tonight. And again, I just want to say a quick thank you to Megan for making herself available tonight to talk about the Accelerating Kids Access to Care Act. So to just get the ball rolling right out the gate, I think probably the best place to start is just a high level set for you, Megan, which is what are the basics? What does the bill do?
Sure, and thanks, Joel. Thanks, Paul, and thanks everybody for having me. Good to be here with you and to talk about advocacy is what I do day in and day out. And happy to talk about this bill. And thanks so much for prioritizing it. So the Accelerating Kids Access to Care Act, to put it simply, it creates a streamlined pathway for Medicaid provider enrollment. What does that mean? Let me explain the scenario. So, as many of you know, when you have a child, you are a child or you have a child, especially with a complicated or a rare condition, oftentimes there's only a few providers around the country that know how to treat that condition, or know the exact procedure that they need, or there's specialists at different children's hospitals and other places around the country that you want to go see. Well, when you're in the Medicaid program, you probably also know that Medicaid is a state-by-state program. So every state runs its program individually. So in the case that your home state clinicians, if you're in the Medicaid program in this case, your home state clinicians decide, you know what, whatever treatment this child needs to happen at XYZ facility in another state. They go ahead and decide that clinically, and perhaps even the administrative stuff starts happening, and the hospital that you need to send the child to negotiates with your home state Medicaid program, and they decide, yes, they need this treatment, this service, this surgery, this gene therapy, and they might even negotiate the rate for that, and kind of put all those ducks in a row. Well, once that happens, that hospital in another state has to actually enroll in your home state's Medicaid program. It sounds simple, but because there's 50 different Medicaid programs, each one has a different enrollment process. And what we found is that a lot of times that part of the process can really be a holdup, and it's really kind of just an administrative burden that takes time while the child is waiting for that care. So what the bill would do is create an optional pathway that Medicaid could implement for states to take up. And essentially what happens is if that facility where you're trying to send the child is in good standing with their home state Medicaid program, and they're possibly enrolled in Medicare or have other kind of good standing, then they can much more easily and quickly enroll in that other state's Medicaid program. And Joel probably asked me more questions about this, but I will say, you know, there's a lot of cases where there's regional care, especially here on the East Coast. You've got a lot of states next to each other, or you've got border states. And a lot of times that part is not a problem, right? Because the children's hospital or the facility you're talking about sees a lot of patients for not complicated and complicated things across state lines in that border area. So they've already worked it out with those border states, but it's really when they see patients that they only see maybe once a year or once every other year that it really takes a long time to get that enrollment in place. So that streamlined pathway will be much needed.
Thanks, Megan. And yeah, to kind of continue along that thread, you've already touched on a little bit, but obviously every state's Medicaid program is different. It's going to vary patient to patient. But as things stand right now without the streamlined program, about how long can it take to get that enrollment process going for seeing your doctor out of state?
It does really vary. So I don't have an average, but we've just heard stories from both the provider side and the patient side of it taking weeks to months. And some of the stories I've heard is, okay, we've got the care all set up. We need to see a patient from Nebraska in Massachusetts, and then everything's all ready to go. And Boston Children's tries to enroll in the Nebraska program, and Nebraska, and I'm just using sample states. I don't know if this is how Nebraska's program works or not, but they say, okay, great. Now send me the social security numbers of every single doctor at the hospital. And as you can imagine, that would both take a lot of time and also have some privacy issues and other things. So sometimes it's like weird requirements like that take a lot of time. Sometimes it's simply just a backlog of paperwork that takes time. But we've seen definitely weeks or months that the child should not be waiting just for an administrative burden.
Yeah, especially with how progressive these conditions can be, we really want to make sure we're getting those kids in as quickly as possible. So continuing along that thread, how does Medicaid as a program work since it's both state and federally run when we're talking about a program like this?
Yeah, and that gets a little bit to the legislation as well, and we'll talk about kind of where the legislation is in the process. But sometimes because CMS oversees the Medicaid program, so the kind of federal agency, but it really is designed and operated and run by each state. And so often Congress and CMS don't necessarily want to tell states exactly how to do something because they're supposed to be able to run it themselves. So that's why this pathway is voluntary, and we think it's something that hopefully states would be interested in taking up. And if CMS kind of encourages it, then that would be even more helpful. And so as we've gone through the legislative process, a lot of groups support the bill. So a lot of patient advocacy organizations like your own, a lot of children's hospitals, including Children's Hospital Association, NORD, who's on the call, supports the bill. And we also work it with LLS, the Leukemia and Lymphoma Society. And then we, of course, run it by other players, including groups like the Medicaid Directors, National Association of Medicaid Directors. And they, just to get to the state-federal interplay, they also don't like telling their Medicaid programs what to do, but they don't oppose this legislation. They're okay with it.
Awesome. Always good to have broad stakeholder support for these things. Do we know about how many children would be impacted by this bill?
Yeah, that gets a little bit to what I was saying about the regional care. I think the largest volume of children, of course, are going to be the ones in the facilities region. So I don't have exact numbers, but we're not talking about a huge volume of kids, right? It's kids with rare diseases. It's kids that really cannot find that care in their home state and need to travel across state lines. And again, the home state Medicaid program has to authorize it. So they're not going to do that just in any different case, right? Like they're only going to do it if that care really can't be provided in the home state. So we're not expecting it to be and we don't expect that with this bill, all of a sudden a bunch of new patients will want to cross state lines, right? It's really just to accelerate the care for the existing population that needs to do this anyway.
Yeah, that makes sense. So I've still got a couple more questions for Shannon, but I do want to go ahead and put the call out to everybody listening in to go ahead and get your questions in the Q&A box, as we'll be wrapping up the, let's say, scripted questions here in just a second. So make sure you get your questions in now. So now that we kind of have a background for what the bill is and what it seeks to do, where is the bill in the legislative process, and how are we looking in terms of likelihood of success?
Yeah, and exciting to hear that you're focusing on these bills that you really think have a chance to pass this year, and this one definitely falls into that category. So it's bipartisan and bicameral, which means it's in both the House and the Senate. On the Senate side, it's led by Senator Grassley and Senator Bennett, so Republican and Democrat, and then Senator Trahan and Senator Congresswoman Trahan and Congresswoman Miller Meeks on the House side, and over 100 bipartisan co-sponsors on the House side. And the very exciting news is this year it's actually made it through the legislative process in the Energy and Commerce Committee. So it was part of a legislative hearing, and then it was marked up in the Health Subcommittee, and it is now passed unanimously out of the full Energy and Commerce Committee, which means two things. It means, one, you actually can't add new co-sponsors once it's passed the committee. So if you're making your ask to your member of Congress, if they're not already a co-sponsor, which they might be since there's 100 of them, they can't technically co-sponsor it, but they can still support it, and they can support its passage on the House floor. And then secondly, it means it's eligible for the House floor. So we're hopeful that there's a chance that it could actually be put on the House floor as an individual bill, because it's a very small, technical, non-controversial, bipartisan and a piece of legislation. And the other thing it has going for it is that it does not cost a lot of money in congressional terms. A little bit of inside baseball, but when CBO, the Congressional Budget Office, first looked at the bill, they didn't understand the full dynamics of what it was doing, and they thought it actually was to incentivize more out-of-state care. And so they scored it as costing a lot of money, $5 billion, which is a lot of money and not something that would be easy to pass in Congress. Well, once we explained to them, actually it's just existing care getting done a little bit quicker and could actually save money because a kid is not going to be sitting in the ICU waiting for the care that they need. They ended up reducing that price tag much, much lower. And so that part of it also makes it smoother to get through the legislative process. So we're hopeful that it has a chance of actually getting on the House floor and getting passed there. We don't see any opposition there. And then I would say pretty much everything in this Congress for the rest of the year is really looking at a year package, a lame duck package after the elections. As everyone knows, a lot is going on with the elections, and Congress gets a little bit distracted from legislating. So it's possible that it could pass sooner, but most likely it would end up in some sort of end of year package.
And that brings us really nicely to the last thing that I want to ask, which is we'll have our own action alert up here in the next couple of days and weeks. But for now, how can advocates help to push the bill forward?
Yeah, I mean, using MDA's action alerts is fantastic. And like I said, your house members can't really co-sponsor anymore, but hopefully they already have. But you can still urge them to support it on the House floor. Senators can still co-sponsor the Senate bill, so definitely urge them to do that. I think they've been trying to add, senators in a bipartisan fashion, but at this point, it has so much support that I think they'll take any takers now. But wanted to kind of build up that co-sponsorship with Republicans and Democrats at the same time. So yeah, urge co-sponsorship and then urge passage this year. We really think has a chance. So it's something that hopefully you won't get too much pushback on.
Awesome. So with that, I'm going to turn it to our audience questions here for the last couple of minutes. Let's see here. Crystal asks, so the bill would kind of set up like a state licensing board. NRN, for example, there are states that participate. So I think what she's asking is, how do these states set up licensing for Medicaid programs?
Sure. So it wouldn't go so far as to create kind of a new entity or something like a licensing board. It's more, and the scenario that I deal with the most is a hospital. So like the entire hospital enrolling in a Medicaid program, usually a children's hospital. So it's really just the children's hospital applying to Florida state Medicaid program or whichever state it is to be enrolled in their Medicaid program. So if the children's hospital is not in Florida, they wouldn't normally enroll, but they're trying to enroll. I think one point that we touched on but didn't go into detail on is that the bill itself is just about that provider enrollment piece. And it, as I kind of stated in the beginning, it does not touch whether or not a child is authorized for care. And it also does not touch the payment, which because states do their own Medicaid programs, they have rates within their state. So if it's something out of state, they typically negotiate. It doesn't affect any of that. It simply is that enrollment so that the home state and make sure that the hospital trying to enroll meets all of their credentialing, all of the requirements that they have to meet to be a provider in that state. Does that answer the question?
Yep. That's been a hugely important piece on the lobbying side of the House. I'm glad that we could get that out to advocates as well. Nancy asks, do all states participate in Medicaid? And if not, what happens to those children?
All states do have Medicaid programs. They do have different eligibility for who is able to be eligible for Medicaid. But yes, that's another good point, is that this is specific to children in the Medicaid program. So if you have private insurance, or I guess it's the only other means for children, since you're generally not going to have Medicare, if you have private insurance, this doesn't apply. And you would, there'd be a different process for that. It's more just for the Medicaid enrollment. So in those states, I would hope that the children have private insurance, and if they're uninsured, then that's a whole other question. But
yeah, that makes sense. So with that, I think we can end our session a little bit early, and Paul, I can pass it over to you.
I'll put the bill numbers in the chat. Yes, thank you.
Awesome. Thanks so much, Megan.
Yeah, thank you, Megan. I know you also have other commitments this evening, so really appreciate you spending a little while talking to us about the Accelerating Kids Access to Care Act. Just to add a little extra punctuation to a couple of things that Joel said for everybody to remember, we will have action alerts for this available here in the upcoming days. So keep an eye out on our X page or in your email or really anywhere that you communicate with us, because we're going to be asking you to contact your senator to ask for their co-sponsorship, to contact your House member to ask for their support if and when the bill is voted on the floor. And so we're going to need your help to get this across the finish line by the end of the year. But we are hopeful that it's going to happen. Okay, and Megan put the bill numbers in the chat as well as the Q&A, I believe, in case you want to go search those and read the bill text yourself. Who knows? Maybe we have some aspiring legislative analysts on the call with us. So why don't we move on to the next topic, our second topic for the evening, and that's on the reauthorization of the Rare Pediatric Disease Priority Review Voucher Program. And I'm very pleased to be joined by Haley Mason. Haley is a policy analyst at the National Organization for Rare Disorders. And NORD has been a longtime leader in supporting not only incentives, generally speaking, to ensure that rare disease therapeutic development continues, but also the Rare Pediatric Disease PRV program specifically as an important incentive for therapeutic development for rare pediatric diseases. So with that, Haley, I don't think I want to say any more because I'll probably be taking from your presentation. So why don't I hand it to you and you can tell us more about the program and why we need to reauthorize it.
Of course, and thank you so much. For y'all that don't know, Paul and I have been working very closely on this reauthorization, and he is helping us out Tuesday at a Senate briefing on this very bill. So we're very excited to be collaborating on this effort and really looking forward to get it over the finishing line. So I'm talking to you today about the Priority Review Voucher Program, and we say that it's a vital incentive for pediatric drug development. As I think everybody is aware on this call, rare disease drug development is particularly challenging and even more uniquely challenging for pediatrics. Something we say at NORD is that children are not just small adults, and they need special consideration and time and effort to make sure the drugs and therapies that they receive are effective and safe for them. So a little bit about the program is that the PRVs are incentives for drug companies to study the hard-to-reach populations for rare diseases. Upon approval of a therapy, drug companies can then receive a PRV if FDA deems that they are qualified to do so. This means that the drug has to be a novel therapy for a pediatric rare disease and have a designation in this. Companies, once they receive a PRV, have two choices. They can either keep it and redeem it for a second drug that they themselves develop and get their second drug then reviewed 4 months faster, or they can sell it to another company, which will then buy it from this first company and use it to get their own drug on the market 4 months faster. So we see this second option a lot of companies selling this, and we really do see this as like an economic incentive for smaller drug companies to research these rare diseases for these underrepresented populations. And lucky for you guys, NORD has been doing a lot of research in this very topic since January, and we actually just finished our paper today. So I have a lot of evidence on the program that this works. And we've been talking to a lot of Senate offices and House offices with this data and really bringing the point home. However, this program is set to end on September 30th, 2024, and it's kind of more and more looking like it might be put in with the Accelerating Kids Access to Care package and sort of passed in this lame duck. So I'm not sure how confident I am that it'll get passed in the September 30th deadline, but I'm more confident that it'll get passed in 2024 in general when we have a lame duck. And I want to say, what can you do about this? I do think MDA is doing an action alert on all of these issues, and you can use that to make sure your elected officials know your support for this vital program. Next slide, please. All right, so what does this mean for you? How does this come home? How is this tangible? So throughout the Rare Disease Pediatric Priority Review Program, more than 560 rare pediatric designations have been made, and 53 rare pediatric disease PRVs have been awarded. And this is across 39 rare disease states. And I will mention that neuromuscular disorders are the most common disease state that receive these PRVs. And remarkably, 36 of these 39 rare diseases had no FDA-approved treatment prior to the creation of the program in 2012. So this means 3 before 2012. I think it was cystic fibrosis, a rare type of cancer, and I'm forgetting the other one, had treatments on the market before 2012. All the others, including a lot of the diseases that MDA represents, did not have any therapies on the market. And you can see with this chart how the PRV program has been growing and growing, and that there are still more drugs being developed in the pipeline. So we need this program's support. And what we've heard from a lot of companies is that this is a vital incentive for them to keep going and keep pursuing this rare disease research. And I think that's a little bit of what I have for my research. So I don't know if Paul, if you want to go ahead with questions or anything like that.
Yeah, sounds very good, Haley. Thank you. And just a reminder, everybody, to again put your questions that you have for Haley or for me within the Q&A box pertaining to the reauthorization of this program. I just want to emphasize one of the points that Haley just made pertaining to the impact of this program on neuromuscular diseases. There are 3 neuromuscular diseases, I believe, that have had therapies developed within the time frame that you see within the timescale charts on your screen. Those being Duchenne muscular dystrophy, spinal muscular atrophy, and Friedreich's ataxia. Friedreich's ataxia is one of the most recent FDA-approved therapies that received a priority review voucher program that was for Skyclarys within the last couple of years. But before then, I think those of you who are either in the Duchenne community or have been following what's been happening in the Duchenne community know that there have been many therapies approved over the last, I guess at this point, 8 or 9 years, including the exon skipping therapies, including targeted steroids, or even dissociative steroids, including Elevidys, the gene therapy that was just approved within the last a little over a year at this point. And these are the kinds of therapies that have received the voucher and may not have been developed if the voucher was not an incentive for these companies to continue the development of these rare pediatric disease therapies. Within SMA, we have 3 approved therapies that are highly effective, all of whom, of course, are different. All of them are important within spinal muscular atrophy, and all received the voucher upon their approval. And so the chart you see on your screen is an excellent indication of the success this program is having in accelerating therapeutic developments in a very difficult area to develop therapies. I know I was a little bit backwards looking, but just forwards looking for a second before I turn to any questions that you may have. There are a number of rare neuromuscular diseases that still do not have an approved therapy that primarily affects children. A number of the limb-girdle muscular dystrophies, for example, would receive the voucher if a new therapy was approved by the Food and Drug Administration. Same goes for a number of myopathies and other rare neuromuscular conditions, sometimes incredibly ultra-rare neuromuscular conditions. So it's not just that the PRV program has been successful for a community, it's that the PRV program could be incredibly successful for a community going forward, but only if Congress reauthorizes it. So that's why we're talking to you about it today. So let's see what questions that we may have in the chat. There's a question from Crystal, and Crystal asks, how does this go along with orphan drugs? And I think I'm going to, Crystal, maybe just rephrase that just a bit. And how does this go along with the Orphan Drug Act? Because there are incentives within the Orphan Drug Act that are meant to incentivize therapeutic development in rare diseases. So Haley, how does this voucher program work with the Orphan Drug Act and interplay with them to try to incentivize development in this area?
Yeah, so I would say that they kind of go a little bit hand in hand, whereas like the Orphan Drug Act, if a drug is approved through now for a designation of an orphan drug, you can have 7 years of exclusivity within that designation or indication. So for the PRVs, this would be for only pediatrics that have a novel therapy. So for the example of Duchenne, 7 different types of Duchenne and different indications have received PRVs. So this might be a different gene that this is presenting on, or different ages or genders that have received this PRV, or a different just type of mutation that this is going on. They would still get the 7-year exclusivity, but they just have this little extra incentive that is more financial to bring in that capital directly back if they choose to sell the voucher or get this second drug on the market 4 months faster and potentially beat competition.
Yeah, awesome. And I'll add to that the Orphan Drug Act, which has been highly successful for over 40 years now, has been incredibly successful in bringing rare disease treatments to market, generally speaking. But the reason this program was created, the voucher program was created, was because there was definitely a tilt towards adult therapeutic development within rare disease therapeutic development overall. Hence why it was obvious there needed to be an additional incentive for the additional difficulty in developing therapies for pediatric rare disease populations. Haley, I have another question for you because within the neuromuscular disease patient population, there are a number of diseases in which individuals may be diagnosed when they are kids. Perhaps the disease first manifests in childhood, maybe even teenage years for that matter, and they're diagnosed soon after manifestation of symptoms. But then they're living into adulthood as well. There are individuals who are both children and adults within the disease community. So how does the policy, how does this program impact therapeutic development for those conditions that have both pediatric and adult populations within the overall disease population?
Yeah, so what I'll say in our research, when looking at the specific diseases that have benefited from the priority review voucher program, say that there's a specific type of Duchenne where the outlook wasn't good. Say maybe people only typically lived until they were 5 years old, had a very, very short life. Now that we see after the pediatric or priority review voucher program has been put in place since 2012, people are living longer and longer with these conditions. I believe now they'll live past 20 or 30. So this is really incentivizing companies to really solve this issue and make sure that people live longer and more healthy lives.
Yeah, absolutely. And actually, I'll give the example specifically of Friedreich's ataxia, actually, in which oftentimes individuals with FA are diagnosed. Sometimes they're diagnosed in their early childhood, but oftentimes, most commonly, individuals with Friedreich's ataxia are diagnosed in their teenage years. And they're diagnosed around the ages of 15, 16, 17 years old, for that matter. And then they live into their 20s, and many individuals live into their 30s and their 40s. But the way that the policy is constructed is that if there is, I don't know if there's a precise percentage or number per se that the FDA uses to decide if the disease is pediatric or not. But if there is a pediatric population, particularly at symptom manifestation, which is the case for many of the neuromuscular diseases in our portfolio, then it would be considered a pediatric disease. And so that's why a number of the limb-girdle muscular dystrophies would qualify for this program. Maybe even FSHD could potentially qualify for this program. And Haley, I'm throwing a lot of different acronyms of neuromuscular diseases that you have 7,000 diseases that are in your portfolio. We have a few less than that within the Muscular Dystrophy Association. Nonetheless, these are all examples of how for the adult populations within the neuromuscular disease community, therapies can still be incentivized for development within this program with a pediatric name in the program that would still benefit those in adulthood. Take Spinraza, for example, within spinal muscular atrophy, a drug that was approved for SMA that got the voucher. And I know individuals in their 50s and 60s with spinal muscular atrophy who have benefited from taking Spinraza. So just for those adults perhaps who are tuning in and wondering, could this program actually benefit me or benefit my family or whoever it is? Possibly. If the disease is also in the pediatric population, then very possibly. I'm going to take one last turn to the Q&A here before I turn it over to Shannon for our final area. Renee, you made a comment that you were wondering about that very question about the diseases in which the disease affects both children and adults. So I'm glad that we were able to cover that question. It's a question that I get a lot as well, kind of where's the cutoff? Because a lot of diseases are in both children and adults. And other than that, I don't see any additional questions in the chat. So Haley, I think with that, maybe I can turn it over to our third issue, our fifth and sixth speaker, if you will. And I'll just extend my gratitude, Haley, again for joining us this evening. Extend my gratitude to Nord for leading us in this area. And with that, Shannon, I'm going to turn it over to you for the SSI Savings Penalty Elimination Act.
Thanks, Paul, and thank you, Haley. Hi, everyone. For those who haven't met me, I'm Shannon Wood. I'm Director of Disability Policy, and I joined MDA back in early April, so this is the first time you've seen me on these institutes. So I am super pleased to be here with you all tonight and to introduce the speaker on our next and last policy priority, which is Supplemental Security Income, or SSI, Asset Limit Reform. In particular, we're going to be covering a specific piece of legislation, the SSI Savings Penalty Elimination Act, which is really strong bipartisan legislation that would raise the asset limits and also index them for inflation. So I'm very excited that speaking with us tonight is Darcy Milburn. Darcy is the Director of Social Security and Healthcare Policy with the ARC of the United States. She is an SSI policy expert and really leading the way on advocacy efforts to strengthen SSI and hopefully bring it into the 21st century. So without further ado, I'll turn it to Darcy.
Unmute. Thanks so much for that introduction. I'm really glad to have the opportunity to join you all tonight and to talk about SSI. Next slide, please. Okay, so folks on this call, some of you may not be familiar with SSI. Others may have direct experience with SSI and lived expertise. But I'll just provide a little bit of background. So SSI is the Supplemental Security Program. It provides monthly cash assistance to people with disabilities and older adults who have little income and very few assets. The benefits are means tested. It means you have to comply with very, very strict eligibility criteria with the amount of money you're allowed to make and the amount of money you're allowed to have in order to qualify. They're super difficult to get. They have very strict medical criteria, and the application process is a nightmare. Ultimately, 6 in 10 applicants are ultimately denied. The benefits themselves are relatively modest. The average benefit is $696 a month. That said, these benefits are critical for meeting people's basic needs, and they do help confer eligibility for Medicaid. So in a lot of cases, SSI can act as the key that unlocks access to healthcare as well. And this chart just shows the level of financial insecurity that SSI beneficiaries have. More than half of SSI beneficiaries have no other source of income than the SSI benefit. Next slide, please. And so who are we talking about and what's at stake with the bill that we'll be discussing tonight? So there's 7.4 million beneficiaries. 84% are eligible due to a disability. The remainder are eligible due to their age being over the age of 64. There are around 1 million children who are beneficiaries of SSI. Roughly half of SSI beneficiaries have incomes below the federal poverty line, even with including their SSI benefits. And 52% of SSI beneficiaries also receive SNAP benefits. So that's just another example of just the financial insecurity that most SSI beneficiaries are dealing with. And this chart just shows the age breakdown of SSI beneficiaries. Next slide, please. So what are the asset limits? The asset limits are the total amount of financial resources that someone on SSI is allowed to have at any time. And for an individual, that asset limit is only $2,000. For married couples, that asset limit is only $3,000. And what that means is that that's the full total of their cash on hand, their money in bank accounts, most retirement accounts, stocks, bonds, the value of life insurance policies, and burial funds over a certain amount of money, as well as the value of some personal property, such as a second car and other household items. These asset limits have not been updated in 40 years. And this chart shows just how much inflation has eroded the asset limit over time. If the asset limit had been indexed to inflation from the beginning of the program, the asset limit for an individual would be over $10,000 right now. Next slide, please. So, and folks on this call may have a broader and deeper understanding of what this impact actually is, because they're living it. But the asset limit really forces people to live in extreme financial precarity. It undermines housing security, food security, financial independence, emergency preparedness, health, well-being. Just think about where in the country is it possible for someone to save to have enough money for a security deposit, first month's rent, and moving expenses that's under $2,000? It just makes things very challenging for people unnecessarily and arbitrarily. It also creates a lot of mental stress on people. It's an incredible burden to have to worry about how much money is in your bank account at any given time, compounded by the fact that most of these people are already living in poverty, but they have to worry about when a particular check might be cashed or when they're getting paid to make sure they don't bounce over the asset limit at a given time. And it really threatens the continuity of benefits. Around 70,000 beneficiaries have their benefits suspended each year due to the asset limits. And even more broadly, and we'll talk about this a little bit more, but the asset limits directly punish paid work, pursuing paid work. It punishes someone trying to save for their future, trying to be financially responsible, and it also penalizes marriage. Next slide, please. Okay, so the bill we're going to talk about, it's the SSI Savings Penalty Elimination Act. I have the bill numbers right there. The bill is bipartisan and bicameral. It's led by Senator Sherrod Brown from Ohio, Senator Bill Cassidy from Louisiana, Representative Danny Davis from Illinois, and Representative Brian Fitzpatrick from Pennsylvania. For folks who've been following this issue for a little while, this is the second time that the bill has been introduced. Last Congress, it was only introduced in the Senate. So this Congress is the first time that the bill has been introduced in a both bipartisan and bicameral fashion. And the bill would take a big step towards modernizing the asset limits. It would raise the asset limits for individuals to $10,000, very similar figure to what it would have been anyway if it had kept up with inflation from the beginning of the program. And it also corrects that marriage penalty that I was talking about, because it raises the asset limit for married couples to $20,000. And then it would also index the asset limits for inflation moving forward, so we don't have to knock on our member of Congress's door in another 40 years to say, hey, we need another asset limit update. Next slide, please. So who supports the bill? MDA does, and I'm really grateful for your support. We more than 400 disability advocacy organizations have endorsed the bill. We also have strong support from businesses, including Microsoft, JP Morgan Chase, a bunch of banks, and insurance companies, such as Nationwide. It makes sense if you think about it. Banks want people to be able to have money in their checking accounts. It makes good business sense for them to have this law passed. Business groups are also supportive. The U.S. Chamber of Commerce has endorsed, and then also business associations like the Food Association, which represents food retailers and other industries in the food sector, supports it. Lots of faith groups. In part because of the marriage penalties, because they see these marriage penalties as a barrier to people being able to live their faith and their values. Think tanks across the political spectrum, from the Bipartisan Policy Center to the Niskanen Center, and also voters. Polling shows that 8 in 10 Democrats, more than 7 in 10 independents, and more than 7 in 10 Republicans support the proposal. Next slide, please. Okay, so it's fairly uncommon for in the history of the SSI program to have big name business leaders support improvements to the SSI program. So I just wanted to pull out two quotes that happened late last year during a hearing. JP Morgan Chase CEO Jamie Dimon said the reason why he supports the bill is because we have employees who don't want us to increase their salary because if it goes over a certain amount, they can't get the benefit to which they're entitled. He means SSI. And he says this definitely should be fixed. And it's true. We've heard from many businesses that employees have to turn down raises, bonuses, more hours, and even retirement benefits provided by employers out of fear of the asset limit itself. And Citigroup CEO said she supports the proposed changes fully and wholeheartedly. So this is this is pretty great. Next slide, please. Just another aside about marriage equality. So the reason why this is a marriage equality issue is that if an SSI beneficiary marries either another SSI beneficiary or someone who's not an SSI beneficiary, the amount of financial resources, the asset limit that this new couple is subject to is actually lower than what it would have been if they'd remained apart. Couples have to hold 25% less assets when they're married. And it's an injustice that it should not exist in today's day and age. What should be a personal decision about love, faith, and commitment is really turned into a financial dilemma. And this image is a photo of a rally for marriage equality that happened on the National Mall last year. Next slide, please. Okay, so getting towards the end, where are we now? The latest update was that just earlier this month, on June 18th, there was a Senate Finance Committee hearing that discussed the bill. So that's that checks that box. It's the first among the first times that this bill has been discussed in committee. In terms of where we are in getting co-sponsors. So in order to ensure that the bill is as bipartisan as possible, the strategy that the co-leads are taking is something called Noah's arcing, which means they are adding a Republican, and a Democrat 2 by 2 by 2. And that means that they do not allow a Democrat to join the bill unless a corresponding Republican is ready to join the bill at the same time. This means that what we have now is a waiting list of Democrats that want to join. And so we are focusing our efforts on trying to get more Republicans on the bill. But you'll see from our list of 12 Senate co-sponsors a pretty broad variety of different members of the Senate, from Senator Brown, who's been a champion on this issue for a really long time, to Senator Scott from Florida, who has not engaged on this issue previously. And then there's 32 House co-sponsors currently. There were too many names to add to one slide. Our advocacy targets right now are pretty much everyone who's not already on the bill, but in terms of where we're focused now, it's the Senate Finance Committee members and the House Ways and Means Committee members. The main hurdles that we have encountered in our meetings with potential co-sponsors, the first one is the cost. The CBO score it estimates that passing the bill would cost $10 billion over 10 years. I think that score is high, but it's what we're working with, and we're still hopeful that that we can convince senators and representatives that making this change is worth the money. The other hurdle we've been experiencing is just the lack of moving legislative vehicles this Congress. There have been multiple times when we've tried to get the bill tacked into a broader package of things that then fell apart. And so it's looking like we're going to have to focus our efforts in getting it included among the grab bag of things that are pulled together in the lame duck. And I think that may be my last slide. Thank you. Really excited to talk through various questions.
Thank you, Darcy. That was such a great overview and really exciting just to see how many partners we have in this fight. So we do have a few questions from the chat trickling in. Lynn asked a question, is SSDI a better opportunity than SSI? Which I think this is an important question. SSDI and SSI are two very important programs that are administered by the same Social Security Administration, but there's pretty unique differences between the two programs. Darcy, do you want to give a brief overview of the differences here?
Sure. Yeah. So SSDI operates a little bit more like like an insurance policy, like almost kind of like a disability insurance policy, where you pay into it through your paycheck every month. And if you become disabled, you are eligible to have the SSDI benefit replace earnings from work. The SSI program operates a little bit differently. It's actually from general tax revenue. So any changes to SSI do not impact the Social Security Trust Fund. It doesn't impact solvency or anything. So that is helpful in a lot of ways. And it in terms of the general experiences of whether it's easy of SSI versus SSDI, SSDI beneficiaries don't have to deal with a lot of the extremely burdensome rules like asset limits that SSI beneficiaries have to deal with. SSDI payments also generally tend to be larger than SSI payments, but because SSDI eligibility stems from your work record, not everybody who needs support and income assistance is eligible for SSDI. Instead, they may only be eligible for SSI. So it's and also you can be on both SSI and SSDI at the same time. So they operate in slightly different ways, and the people who benefit from those programs actually overlap in a lot of cases.
It's a great explainer. Thank you, Darcy. The next question comes from Kelly. She asked, what about healthcare companies? I think this is in relation to what kind of groups are supporting the bill. Are there any healthcare companies supporting the legislation?
Yeah, well, so as part of our outreach, there are a number of health service providers, especially those who provide services to like long-term supports and services, support the bill. The particular names are escaping me. I will say we haven't spent much time and energy trying to get like hospital systems or too many health stakeholders engaged, because it would have required a bunch of additional advocacy work that we didn't have the time to do. But if we are still in this fight next Congress, I think there's scope to add even more support from businesses, including businesses from the healthcare industry. There isn't anybody from the healthcare industry that I'm aware of that does not support the bill or is against the bill.
That's great. And it's also important to note out that there's a lot of patient and disease organizations that were included as part of that 400 number of organizations that are supporting the bill. A couple last questions. This bill has a bunch of co-sponsors in both the House and Senate. GovTrack gives it a 0% chance of passage. And I think, Darcy, one of the questions I wanted to ask of you myself, and I think it's one we're used to hearing on the Hill, is when our advocates speak to members of Congress or staffers about this bill, they might hear, it costs too much money, it's not in the cards. How might you counter that argument?
That's not just a question, that's the question. I think one thing that's important to emphasize is just how long SSI beneficiaries have been waiting for change. It's been 40 years since this asset limit has been raised, and it is a change that is long overdue and will benefit our economy significantly. I think that the best arguments for those kinds of concerns about cost are emphasizing how the bill will help people re-enter the workforce, will help them work more hours, will help them pursue employment opportunities that they otherwise might not be able to. And there's a lot of benefits, economic benefits, to the bill that are not captured by the CBO score itself.
Absolutely. And I think that even came up in the Senate Finance Committee that a lot of this money is going to go back into districts, into states. So, Darcy, thank you for that overview. Thanks for entertaining those questions. And before I turn it back to Paul, I will just say for anyone listening who is rearing to go and ready to advocate now, I have great news, and that's that we have an action alert up on our Action Center right now, and urging your member to co-sponsor the SSI Savings Penalty Elimination Act. So we'll make sure that that link gets circulated again in the chat. But Darcy, again, thank you. And with that, I'm going to turn it back over to Paul.
Thanks so much.
All right, thank you so much, Darcy. At the outset of our agenda, I mentioned that we'll spend just a minute or two on just as brief of a summary as we can on all the other things we have going on, because you've heard us just talk about 3 bills and 3 issues this evening. And we don't want to leave you with the impression that that's all we're up to over here, because there's still a lot that we're making progress on, and that we have some hope that we actually can get done by the end of the year. And you can see some of those issues here in front of you, additional things that we're prioritizing. Within our access to care portfolio, we're actually expecting to be able to get telehealth coverage and access extensions across the finish line by the end of the year. They actually have to be passed by the end of the year, and it's looking pretty good that they will. But in addition to that, we're still working to pass the ALS Better Care Act, a bill that will extend additional coverage for multidisciplinary care for the ALS community. We're trying to still pass increased access to genetic counseling services, as well as facilitate value-based purchasing agreements for complex therapies, and that includes gene therapies. Within our accelerating therapeutic development area, in addition to trying to get the rare pediatric disease priority review voucher passed, we're also trying to close a loophole that's within the Orphan Drug Act that needs to be closed through legislation, as well as pass the NIH Clinical Trial Diversity Act, a bill that many of you heard us talk about in our last Advocacy Institute just last month. And then finally, within our disability policy portfolio, the area that Shannon oversees, in addition to prioritizing reforming our SSI program, we're also looking to strengthen access to home and community-based services in additional efforts to modernize SSI and SSDI outside of the SSI Savings Penalty Elimination Act, which is what we summarized today. And that's just for this year. We have many things we're already dreaming up for next year, in newborn screening and accessible housing and access to careers and to education and access to medical devices and many other areas that we expect to be active in legislatively going forward. But really, we wanted to focus on this year and what we're going to try to get done by the end of the year. Of course, those 3 bills that we focused on, and we're going to need your help in doing so. So why don't we move to the final slide here, which is, again, just a reminder for how you can join us if you're new to us, or if you haven't joined us on these web pages before, mda.org/advocacy. You can email us anytime you want. It's Jory who's manning the inbox. Jory, thank you for manning the inbox. It's advocacy@mdausa.org. or you can text MDA USA to 50457. And just again, as we said, action alerts on these three will be active within the upcoming days. Also, within SSI, I don't know if we had a chance to mention, we want to hear your stories about your experience with SSI, because it's the stories of our community and the disability community more broadly that are going to make the impact up on Capitol Hill, more so than me talking about it or Shannon talking about it, or folks who perhaps don't have that personal experiences, those personal experiences that make all the difference. So please do share those with us if you have them. I know we're 2 minutes over already, and we've already been taking lots of questions as we've been going on. I'm going to see if there's any other final questions that we have. We do have one question, and Darcy, this is getting into the weeds of the SSI Saving Penalty Elimination Act. I do think you're still with us if you don't mind answering just one more question past our hour. And Crystal asks, is there also technically a deflation period that would be within the SSI Savings Penalty Elimination Act? If it's adjusted for inflation, is it also adjusted for deflation?
That's a great question, and I love weedy questions. Like most other Social Security benefits, it does not have a deflation arrangement. So that's generally in terms of how other Social Security benefits work, that they the rate of increase will just be lower rather than have a deflationary change to the benefit or to the asset limit.
That's right. I think that's right, Darcy. And reflecting on another issue that we're facing right now within Social Security, and that's Social Security clawbacks, in which the Social Security Administration is actually asking for money back from the disability community. We've got to be very careful about benefits actually decreasing, or in some ways money actually going out of the pockets of those with disabilities, rather than at the very least keeping things even if there is no inflation, but still trying to keep up with inflation, which is the much bigger issue of all of these. So thank you for answering that question. I'm going to just do one final scan to make sure I'm not missing anything else. I think that actually we are all fine, and we're 4 minutes over anyway. So with that, I'm just going to wish everybody a very happy remainder of your Thursday. Thank you again for joining us tonight. You'll see these action alerts coming soon. Please do email your congresspersons in support of this legislation, and we look forward to seeing you again sometime soon. Thanks all.